Welcome to the deep dive. We're here to cut through the noise and get right to the core insights. And today we are taking a deep dive into something really transformative in patient care: percutaneous thyroid ablation.
Hmm.
Yeah, I mean, this isn't just, another procedure. It feels like a fundamental shift in how we're looking at thyroid nodules, right? Thinking about patient quality of life, and really using these amazing advances in imaging.
Absolutely. It's a big change.
So we've pulled together a lot of sources, and really our goal here is to break down the crucial stuff for you listening, especially the practical side.
Mhm.
The techniques, managing complications, hopefully avoiding them, and those essential tips and tricks.
Exactly. And, we're seeing so many more thyroid nodules being picked up, largely thanks to high-res ultrasound.
Right, that incidental finding.
That's it. And that's really pushed the need for less invasive options. Surgery, well, it's been the standard,
Yeah, the traditional route.
the traditional route, exactly. But as we'll get into, percutaneous ablation, it offers some really compelling benefits for clinicians like you and definitely for patients. It's really changing the game.
Okay, so let's unpack that. Why has percutaneous thyroid ablation become such a game changer? We know, over 90% of these nodules found incidentally are benign, often no symptoms at all.
That's right. Benign, asymptomatic mostly.
But for that subset that does cause problems, intervention is needed. Symptoms like dysphagia,
Difficulty swallowing, yeah.
throat discomfort, maybe pain, that feeling of something stuck there, or just the cosmetic side of it, a visible lump.
Exactly. And traditionally, the answer was surgery, hemithyroidectomy, total thyroidectomy.
Right. Effective,
But with significant downsides.
but...
You're talking general anesthesia, hospital stays, the neck scar,
Mm-hmm.
and a really high chance of ending up hypothyroid afterwards, which means lifelong hormone replacement.
Which is a huge deal for patients. That daily medication, the follow-ups, potential side effects,
Yeah.
it adds up.
It absolutely does.
Yeah.
Both for quality of life and, healthcare costs long term.
So this is where ablation really starts to shine, isn't it? These techniques are just so much less invasive.
Massively less invasive.
Typically no visible scar, often just local anesthesia in an outpatient setting. Same-day discharge is common.
And much shorter recovery times. That's a big plus.
Yeah, huge.
And critically, the risk of complications is low overall, and you preserve the native thyroid function.
So no lifelong hormone replacement for most people.
Precisely. That's a monumental benefit. It avoids all that chronic medication management.
Okay, so given all that, where does this fit in? What are the specific scenarios, the patient selection criteria that you as clinicians should be thinking about?
Well, it's particularly good for patients who maybe aren't great candidates for surgery because of other health issues, comorbidities.
Right, the higher risk surgical patient.
Exactly. Or simply patients who strongly prefer not to have surgery for a benign lesion.
Patient preference is key.
Very much so. And then you have specific situations like nodules in tricky anatomical spots,
Mm-hmm.
or ones that haven't responded to medical therapy, or maybe multiple small nodules scattered around that would be just awkward to remove surgically.
That makes sense. The reduced impact, the cosmetic side, those are strong drivers.
Definitely.
All right, so before we get into the how-to, the techniques themselves, let's nail down patient selection. It sounds absolutely critical. Who gets ablated and what do you need to know up front?
It is critical.
Yeah.
And it raises that question. What are the precise indications?
Hmm.
Because the evidence is still evolving, right?
Sure.
But the most common reason for thermal ablation, that's RFA, radiofrequency ablation, and MWA, microwave ablation, is for benign, non-functioning nodules that are causing symptoms or cosmetic issues.
Okay. Is there a size cutoff?
No strict universal threshold, but usually they're over 2 centimeters. And really large ones, say over 20 LL, might need more than one session.
Got it. And what about cysts?
Ah, yes. For cystic or mostly cystic nodules, where the fluid part is over 50% percutaneous ethanol ablation, EA, that's really considered the go-to. It just works better for those.
Okay, EA for cystic, RFMOA for solid symptomatic. What else?
Well, there are the autonomously functioning thyroid nodules, AFTNs, hot nodules causing hyperthyroidism. RFA, sometimes MWA, is indicated there too.
Interesting.
And what's also developing is its use in recurrent thyroid cancer.
As to surgery.
Exactly. When doing another surgery is tough, maybe due to scar tissue, RFA can be used sometimes with curative intent for small, localized recurrences or just for palliation, managing symptoms.
Wow.
And there's even emerging evidence for using ablation as a primary option for certain small, low-risk thyroid cancers like papillary microcarcinomas, PTMCs, especially if the patient wants to avoid surgery or can't have it.
That's a significant development. But are there times when ablation is definitely not the right choice? Contraindications?
Absolutely.
Yeah.
Safety first, always.
Mm.
Absolute contraindications would be pregnancy. And having certain cardiac pacemakers, especially for monopolar RFA, bipolar electrodes might be an option there, or a different method.
Right. And relative contraindications, things to be cautious about.
Yeah, things like a nodule extending way down behind the sternum makes it hard to see and reach. Severe bleeding disorders that can't be corrected.
Obviously.
Nodules where the biopsy is indeterminate or malignant, usually, you wouldn't ablate those primarily, unless it's one of those specific low-risk microcarcinoma situations or a recurrence protocol.
Makes sense.
Also, maybe patients with autoimmune thyroid disease or someone who already has vocal cord palsy on the other side. You need to be extra careful there.
Okay, so let's say you've got a good candidate. What goes into that pre-procedure workup? What do you need to tick off the list?
It's got to be meticulous. You start with a really detailed history and physical exam. Are the symptoms really coming from the nodule?
Good.
Then imaging. High-resolution ultrasound is fundamental. You characterize the nodule size, location, composition, blood supply, and crucially map out all the nearby structures. The recurrent laryngeal nerve, vagus nerve, carotid, trachea, esophagus, all the critical anatomy.
You calculate the volume too, right?
Yep, using the ellipsoid formula. Doppler ultrasound checks vascularity. Sometimes you might use contrast-enhanced ultrasound, CEUS.
What about stands?
If you suspect hyperthyroidism or an AFTN, then yes, a technetium or iodine thyroid scan to confirm it's hot. CT or MRI might be used occasionally for really complex cases like those retrosternal ones.
And lab tests.
Full panel. Blood count, coagulation studies, full thyroid function test, TSH, T3, free T4, maybe thyroid antibodies, calcitonin. You want to correct any issues beforehand if possible.
And the biopsy confirmation is essential.
Absolutely critical. Fine needle aspiration, FNA, or maybe a core needle biopsy, CNB, to rule out malignancy. Typically, for a benign, non-functioning nodule, you want at least 2 separate benign results from US-guided biopsies.
Too benign. Okay.
Unless the ultrasound features are super specific for benign, like a purely cystic or a spongiform nodule, then maybe one is okay. For AFTNs, one benign FNA is usually enough. For recurrences, you need that confirmation too, maybe with checking thyroglobulin levels from the needle washout.
And checking coagulation status, stopping blood thinners.
Crucial. Patients usually need to stop anticoagulants or antiplatelets for a set period before the procedure.
And finally, the discussion with the patient.
Yes, comprehensive counseling. Go through the procedure, the benefits, the risks. Really important to manage expectations, especially about maybe needing more than one session for bigger nodules, and discuss the alternatives, like monitoring or surgery. Informed consent is key.
Might you do a laryngoscopy beforehand?
Sometimes, yes. Especially if there's any voice change already or concern about the nerve's position, you want that baseline vocal cord function check. It's all part of that rigorous planning for safety and success.
Okay, let's dive into the procedures, the techniques. For our listeners doing these, what are the core principles?
Right, the how-to. At the core, all ablation aims to cause irreversible cell damage.
Kill the nodule tissue.
Exactly. Thermal ablation, RFA, MWA, laser, even HIFU uses heat. You're aiming for 60 to 100 degrees Celsius. That denatures proteins, causes coagulative necrosis, basically cooks the cells. Okay. Now, a critical tip here. Going too hot, like over 100, 110 Celsius, isn't necessarily better. It can cause tissue to vaporize or char.
Carbonization.
Right, and that carbonized tissue can act like an insulator, stopping the heat from spreading effectively, which reduces how well the ablation works.
Interesting. And what about blood flow?
That's the heat sink effect. Nearby blood vessels can carry heat away, which can also make the ablation less effective in those areas. You have to account for that.
Okay, so that's thermal. What about chemical ablation? Ethanol.
Yeah, ethanol ablation, EA, is different. You inject a sclerosing agent, usually pure ethanol. It dehydrates the cells, causing coagulative necrosis, and it also damages the lining of small blood vessels, causing clots and cutting off blood supply ischemic necrosis. Its effect is very localized.
And the universal tip for all of these?
Real-time ultrasound guidance. Always. It's absolutely non-negotiable. For placing the needle or electrode precisely, watching the ablation zone develop, and crucially, staying away from those vital structures nearby.
Okay, let's break down the big ones. Radiofrequency ablation, RFA. How does that work?
So RFA uses high-frequency electrical currents. These currents make ions in the tissue vibrate rapidly, which generates friction and therefore heat.
Got it. And the equipment.
There are specialized electrodes for thyroid RFA. They usually have short, active tips, maybe 0.5 to 1.5 centimeters, and internally cooled shafts. A pump circulates chilled water through the electrode.
Why the cooling?
It prevents the tissue right next to the electrode from charring too quickly, which, as we said, can limit heat spread. Cooling allows for better energy deposition deeper into the nodule.
Makes sense. And the technique, you mentioned a moving shot.
Yes. The moving shot technique is standard for RFA. It's very dynamic. You mentally divide the nodule into many small sections or units. Then you treat each unit by continuously moving the electrode tip, sort of fanning it through that section.
So you're painting the heat across the target area.
Exactly. It ensures you cover the whole nodule thoroughly while minimizing heat exposure to the surrounding tissues. And a key tip for this technique: generally, you work from the deep part of the nodule towards the superficial part,
Why is that?
or sometimes superior to inferior. It's mainly to stop any tiny gas bubbles that form during ablation from rising up and obscuring your ultrasound view of the deeper areas you still need to treat.
Clever.
And you always want to keep that active electrode tip just inside the nodule margin, maybe 1 or 2 millimeters away from the edge. Don't go outside.
What about getting the needle in? Any preferred approach?
The transisnic approach is often favored. You insert the electrode through the thyroid isthmus, the central part connecting the lobe.
Why through the isthmus?
It helps stabilize the electrode, it reduces the chance of hot fluid leaking out into the surrounding neck space, and it generally provides a safer path away from critical structures like the recurrent laryngeal nerve.
Okay. And you mentioned hydrodissection earlier. That sounds vital.
It is absolutely crucial, especially when a nodule is right up against something important. The nerve, trachea, esophagus, carotid artery, vagus nerve, sympathetic ganglion. You inject fluid, usually 5% dextrose water or saline, sometimes with a bit of lidocaine, into that space between the nodule and the critical structure.
Creating a buffer zone.
Exactly. A liquid isolating region. It physically pushes the structures apart, and the fluid acts as a heat barrier, protecting those vulnerable areas from thermal injury. It's a key safety maneuver.
Any other RFA tips? Bipolar electrodes?
Yeah, bipolar electrodes are an option. Unlike monopolar, where the current goes from the electrode to a grounding pad on the patient, bipolar current is confined between 2 points on the electrode itself. This limits the current spread, making it potentially safer for, say, pregnant patients or those with pacemakers.
Good to know. And tech advancements.
There are things like virtual needle tracking systems emerging. They can help beginners by showing the predicted path and real-time location of the electrode tip on the ultrasound image.
Okay, let's move to microwave ablation, MWA. How's that different?
MWA also uses heat, but it's generated by electromagnetic energy, microwaves.
And advantages compared to RFA.
Well, MWA tends to heat up faster, can create a larger ablation zone per placement, and importantly, it's less affected by that heat sink effect from blood flow we talked about.
So potentially quicker, bigger ablation zones.
Potentially, yes. You can often get higher temperatures within the nodule and cover more ground in less time. The moving shot technique is also used with MWA, similar to RFA.
Right. Now for those cystic ones, ethanol ablation, EA, you said it's quite different.
It is chemical, not thermal. Perfect for those benign cystic or mostly cystic nodules, over 50% fluid. And a big plus is that it's really cost-effective. You don't need expensive generators or probes.
Simple setup.
Relatively simple, yes. Can easily be done outpatient with just local anesthetic. There are 2 main ways to do it.
Okay.
The ethanol aspiration technique involves sucking out the cyst fluid first, then injecting 99% ethanol, usually about 50–70% of the volume you aspirated. You let it sit for a few minutes, then you aspirate the ethanol fluid mixture out completely.
Why aspirate it out again?
The idea is it might reduce complications like pain or inflammation caused by ethanol leaking out around the nodule.
And the other way?
Is the ethanol retention technique. Simpler. You aspirate the fluid, inject the ethanol, and just leave it in. No second aspiration.
Which is better?
Retention is quicker, technically easier. But some studies suggest the aspiration technique might lead to significantly less pain afterwards, with similar results in terms of shrinking the nodule. So maybe aspiration is preferable if pain is a concern. Usually you don't inject more than 20 milliliters of ethanol, and you monitor the patient for maybe 30–60 minutes afterwards.
Okay. And briefly, laser ablation, LA.
LA is another thermal method. Uses focused light energy delivered through optical fibers, which gets converted to heat. It's often considered the least invasive thermal technique because the applicators are very small, allowing for precise energy delivery.
What's it used for?
Similar indications to RFM, symptomatic benign solid nodules, sometimes considered for small functioning nodules or even those PTMCs, the microcarcinomas. For good results, you generally need to deliver a decent dose of energy, often quoted as over 500 joules per milliliter of tissue.
Got it. Now, pulling it all together, regardless of whether you're using RFA, MWA, EA, or LA,
Yeah.
what are those universal golden rules during the procedure itself for safety and effectiveness?
Absolutely. These apply across the board. First, anesthesia, usually local, as we said. Lidocaine may be mixed with dextrose to numb the skin, muscles, and the thyroid capsule. Injecting some around the thyroid, parathyroidal injection is good too.
Why not general anesthesia?
Generally not recommended because you want the patient awake or only lightly sedated. You need their feedback. If they suddenly feel pain in a specific spot, or more importantly, if their voice changes, that's an early warning sign of potential nerve irritation or injury. You lose that immediate feedback with general anesthesia.
Right. Makes perfect sense. And constant ultrasound.
Non-stop, real-time U.S. guidance throughout. You need to see exactly where that needle or electrode tip is at all times, watch the ablation zone forming, make sure you're staying in the nodule and safely away from critical structures.
Avoidance of critical structures is paramount.
Paramount. Know your anatomy intimately. Recurrent laryngeal nerve, vagus, sympathetic chain, brachial plexus, carotid, esophagus, trachea. Know where they are in relation to the nodule. Use hydrodissection liberally, especially if you're close. And if that electrode tip starts heading somewhere dangerous, stop ablation immediately. Reposition.
Patient communication, too.
Keep talking to the patient. Ask them how they're doing, if they feel anything unusual, any voice change. That interaction is part of your safety monitoring.
And afterwards, post-procedure.
Monitor them for a few hours. For RFA, often around 3 hours before discharge. Put firm manual pressure on the puncture site for 10-15 minutes right after to minimize bruising or hematoma.
Okay, so you've done the procedure meticulously. What kind of outcomes can patients and clinicians expect? How effective are these techniques?
The results are generally impressive. You see significant reduction in nodule volume, definite improvement in symptoms, better cosmetic appearance, and this is key preserved thyroid function.
Let's talk volume reduction first, VRR.
Volume reduction ratio, yes,
Okay.
that's a main measure. For RFA, studies consistently show mean VRRs anywhere from, say, 47% to over 80% at 3-6 months, and often 60% to over 90% by 1 year. Most shrinkage happens in the first 3-6 months. For benign nodules, getting up to 80% reduction in 6-12 months is typical.
What about comparing RFA and MWA on volume?
Some big analyses, meta-analyses, suggest RSA might have a slightly higher VRR at 12 months compared to MWA, like 83% versus 77% in one study. For those tiny papillary cancers, PTMC, RFA also showed very high VRR, around 99%, with complete disappearance at about 65% of cases.
And MWA on its own?
Also excellent volume reduction. Reports show maybe 75% at 6 months, heading towards 85-90%, or even higher long-term, like 48 months out. MWA might be particularly effective for smaller nodules, say under 10 millirel to start.
And EA for the cystic ones?
EA can be incredibly effective for cysts. VRRs can hit 90% even in functioning nodules, and potentially 100% in purely cystic ones. For those mixed cystic solid ones, using the aspiration technique, you might see around 80% reduction.
Laser.
LA also shows good results, often getting over 50% volume reduction after 6 months to a year, provided enough energy is delivered, like that 500 JML figure we mentioned.
And symptom improvement. Cosmetic results.
That's a major goal. And yes, all techniques consistently show significant improvement. Pressure symptoms like difficulty swallowing, that foreign body sensation, and the visible neck lump, they get much better. For solid nodules treated with our Femwaya, maybe 90% see significant improvement. For cystic ones with EA, it might be even higher, like 95%. This directly translates to better quality of life.
And the thyroid function preservation.
That's the huge advantage over surgery. Because the ablation is targeted just to the nodule, you spare the healthy surrounding thyroid tissue. So patients typically don't need thyroid replacement medication afterwards. Studies confirm this for both RFA and MWA. It's a massive factor for patient satisfaction and long-term health.
What about long-term? Do the nodules ever come back or regrow?
That's a good question. While the short to medium-term reduction is great, there is some evidence that treated nodules can show some regrowth after maybe 2 or 3 years.
Why does that happen?
Often it's if the very edges, the margins of the nodule, weren't completely ablated in the first session. Regrowth might happen in up to maybe 20-25% of cases, averaging around 3 years after RFA. Larger nodules, maybe over 20 millinellar or so, are more likely to need multiple sessions initially to get optimal reduction, or they might have a higher chance of some regrowth later.
So follow-up is important.
Essential. You'll typically do follow-up ultrasounds at 1, 3, 6, and 12 months, and then maybe yearly or every 6-12 months after that, just to track the volume and check for any significant regrowth. But even with potential regrowth, The overall recurrence rates requiring reintervention seem pretty low.
Okay, let's tackle the potential downsides, complications. You said the overall risk is low, but what specifically can go wrong?
Right, the safety profile is generally excellent, much better than surgery. Overall complication risk for RFA is cited around 2–3%. Permanent or severe issues are very rare, definitely under 1%.
Hmm.
And importantly, no deaths related to RFA or MWA procedures have been reported.
That's very reassuring. But what are the things radiologists and ENTs must be aware of? And critically, how do you avoid them and manage them if they happen?
Top of the list is nerve injury, particularly the recurrent laryngeal nerve, the RLN.
Causing voice changes.
Exactly. Hoarseness or a change in voice, sometimes noticed right during or just after the procedure.
Hmm.
The reported rate varies, maybe around 1% up to nearly 5% in some series. But permanent voice change is rare, thankfully less than 1% for RFA usually. Temporary changes are more common, maybe around 1%.
And the temporary ones get better.
Yes, most resolve on their own within maybe 2 or 3 months. You can confirm it with a post-procedure laryngoscopy if needed.
How do you prevent RLN injury? That sounds like the big one to avoid.
Prevention is everything. Comes down to meticulous technique. Know your anatomy, especially that danger triangle near the tracheoesophageal groove where the nerve often runs. Use the transismic approach, use the moving shot technique carefully, and consciously undertreat the area closest to where you think the nerve is. Don't push the heat right up against it.
And the intraprocedural stuff.
Real-time ultrasound monitoring of that electrode tip is vital. Continuous communication with the patient asking them to speak or say, ah, periodically, and liberal use of hydrodissection to create that safety buffer.
What if it happens despite precautions? Management.
Most temporary cases just need observation. They resolve spontaneously. Some might consider a course of steroids, like prednisone. Injecting cold 5% dextrose water around the nerve area has also been reported as potentially helpful.
Okay. Any other nerve issues? Brachial plexus.
Extremely rare, like less than 0.1%. But it could happen if the electrode goes too deep or outside the thyroid capsule. Symptoms would be numbness or tingling in the arm or fingers. Prevention is just careful U.S. visualization of the entire electrode length.
Vagus nerve. Sympathetic chain.
Also rare, but they're nearby. Vagus nerve stimulation could cause a vasovagal reaction feeling faint, slow heart rate. Sympathetic ganglion injury could lead to Horner syndrome, droopy eyelid, small pupil. Again, prevention is anatomy, U.S. guidance, hydrodissection.
All right, moving on from nerves. Local complications.
Pain or a heat sensation during or after is probably the most common side effect. Maybe up to 15% of RFA patients report some. Usually it's mild to moderate, self-limited, gone in a day or two. Can radiate to the jaw, ear, shoulder.
Prevention and management.
Good local anesthesia is key for prevention. During the procedure, if the patient feels too much pain, you can reduce the power or pause the ablation briefly. Afterwards, simple oral painkillers like acetaminophen usually suffice.
Skin burns.
Rare, usually just minor first-degree redness at the puncture site, maybe 0.3% risk for RFA. Resolves quickly. Full-thickness burns are exceptionally rare but reported. Using the transismic approach, careful U.S. monitoring, maybe ice packs can help prevent it. Bipolar electrodes are safer regarding burns too.
Hematoma. Bruising.
Can happen maybe in 1–2% up to 17% in some reports, but usually small, asymptomatic, and resolves on its own over weeks. Prevention is about assessing bleeding risk, stopping blood thinners appropriately using a small needle, and that post-procedure compression.
What about nodule rupture?
Also rare. But the nodule can basically burst if the electrode goes through the capsule, causing sudden neck swelling and pain. Usually managed conservatively with observation, maybe antibiotics, painkillers. Very rarely might need drainage or surgery.
Any other rare things? Infection.
Fever. Infection or abscess is very rare. Some patients, maybe up to 6%, might get a low-grade fever during or right after RFA, but it typically resolves within a day or so. Nausea or vomiting can happen, maybe 1%, resolves quickly. Antibiotics can help. Coughing can occur, especially if ablating near the trachea need extra care there. Some temporary swelling is common, usually settles down. Steroids might help if significant.
Systemic things. Thyroid function changes.
As we said, long-term hypothyroidism is much less common than with surgery. You might see transient thyrotoxicosis, a temporary release of thyroid hormone from the ablated tissue, but it's usually asymptomatic and resolves spontaneously. You just need to monitor thyroid function tests afterwards.
So overall, manage expectations, use meticulous technique, and most issues are minor and self-limiting.
That's the take-home message. The safety profile is very favorable when done correctly.
Okay, we've covered the main techniques, RFA, MWA, EA. For practitioners deciding which to use, how do they compare head-to-head? When would you choose one over the others?
That's a key practical question. It really depends on the nodule characteristics, operator experience, and maybe equipment availability.
Let's compare RFA and MWA first for those solid or mostly solid benign nodules or maybe recurrent cancers.
Right. In terms of efficacy, shrinking the nodule, both are very effective. As mentioned, some meta-analyses suggest RFA might achieve a slightly higher volume reduction ratio, VRR, particularly at 6 and 12 months.
Why might that be?
One theory is that RFA's generally lower maximum temperatures lead to less tissue carbonization compared to MWA. That charring in MWA could potentially act as an insulator, hindering further shrinkage over time. RFA might produce more uniform coagulative necrosis without that intense charring.
What about safety between RFA and MWA?
Generally considered comparable, both have good safety records. Some studies hint MWA might have slightly higher rates of complications like voice changes, possibly due to the higher temperatures or maybe less precise energy control compared to RFA's feedback mechanisms. But overall, major complications are rare for both.
Technical differences. Speed.
MWA usually heats faster and creates a larger ablation zone per application, and it's less bothered by the heat sink effect, so potentially quicker procedures for large nodules. However, some studies have actually found RFA associated with shorter total ablation times, perhaps because the moving shot technique with RFA is very efficient.
Cost and access.
RFA probes tend to be less expensive than MWA probes. The generators might be comparable or RFA cheaper. And in the U.S., RFA has a specific category I CPT code for thyroid ablation, which MWA currently doesn't. That can impact reimbursement and how readily it's adopted.
Learning curve.
Some suggest RFA might be a bit more forgiving or easier for less experienced operators to get consistent results with, maybe due to the controlled heating.
Okay, so RFA may be slightly better long-term VRR, potentially safer profile due to heat control, better reimbursement currently. MWA, faster heating, less heat sink effect. Now, how about ethanol ablation, EA, versus the thermal methods like Arfimoir?
The main difference is the type of nodule. EA is hands down the treatment of choice for benign cystic or predominantly cystic nodules, remember, over 50% fluid. Thermal ablation, RFA or MWA, is best for solid or predominantly solid nodules.
Can you use thermal for cysts or EA for solid?
You can use RFA for purely cystic nodules, and the results might be similar to EA. But for predominantly cystic nodules that still have a solid bit, say over 20%, EA might not shrink the solid part effectively and could have a higher recurrence risk than if you used RFA for the solid component. Trying to use EA on a purely solid nodule generally doesn't work well.
Cost and equipment are big differences too.
Huge difference. EA is much, much cheaper. No expensive generator, no specialized probes needed. Just ethanol, syringes, needles, and ultrasound. Makes it very accessible.
And the mechanism, specificity.
EA works chemically, locally. Its effect is pretty much confined right where you inject it. Thermal ablation generates heat that can spread, which is why hydrodissection is so important with RFA and MWA to protect nearby structures. EA inherently avoids that thermal spread risk.
Could you ever combine them?
Yes, sometimes for complex nodules. Maybe use EA first to collapse a large cystic component, and then come back later with RFA to treat the residual solid part. Or vice versa, use RFA for the main solid bulk, and if a small cystic area remains, maybe inject a tiny bit of ethanol.
What about laser or HIFU in this comparison?
Laser ablation LA fits in with RFAM for solid nodules. It uses small fibers, considered very precise, minimally invasive. High-intensity focused ultrasound, HIFU, is non-invasive, which is appealing, but the data for thyroid nodules is still more limited compared to RFA, MWA, and EA.
So the big picture choice depends heavily on the nodule type cystic versus solid, and then between RFA and MWA for solid nodules, there are nuances regarding efficacy, safety profile, speed, and cost access to consider.
That sums it up well. All offer huge advantages over surgery, but you tailor the choice. RFA and MWA for solid, with maybe RFA having an edge in some analyses for long-term VRR and safety control. EA is the clear winner for cystic nodules, effective, cheap, and simple.
This really feels like it connects back to a fundamental shift, doesn't it?
Yeah.
Percutaneous ablation has genuinely transformed how we manage thyroid nodules. It's a minimally invasive alternative that directly meets patient needs better cosmetics, keeping their thyroid function, avoiding GA.
Absolutely. And it underscores the importance of that whole process we discussed. The rigorous pre-procedure workup, the imaging, the biopsies is non-negotiable.
Yeah.
And then the precision during the procedure itself, using techniques like the moving shot, constant ultrasound, hydrodissection, talking to the patient, that's all vital for getting the best results and keeping complications truly minimal. especially avoiding thermal injury to those critical neck structures.
And while the safety record is excellent, that low complication rate around 2–3%, you still need to be aware of potential issues like temporary nerve palsy, maybe a burn or hematoma, some pain. But knowing most are mild, temporary, and manageable is reassuring.
It is. And the fact that patients keep their own thyroid function afterwards, avoiding lifelong hormone pills,
Yeah.
that is just a massive win for their quality of life.
So where does this leave us? What's the takeaway for practitioners?
I think the takeaway is that percutaneous thyroid ablation is mature technology. The devices are better, the techniques are refined, the guidelines are clearer, it's safe, it's effective, and for the right patients, it should increasingly be considered a first-line treatment option, not just an alternative when surgery isn't possible.
It's definitely an exciting field. This deep dive highlights a real advance in interventional radiology and ENT practice. It's a fantastic example of how innovation directly improves patient care.
It really is. And it makes you wonder, looking forward, detection rates for nodules keep going up, patient-centered care is rightly gaining focus. How might things like AI, integrated with advanced imaging, further refine these techniques?
AI-guided ablation.
Potentially.
Yeah.
Could AI help delineate targets more precisely, predict tissue response, maybe even guide the energy delivery in real time? Could it make these approaches even safer, more effective, maybe applicable to an even wider range of thyroid issues or other neck lesions in the future?
That's a fascinating thought to leave our listeners with. Where could this technology go next? Thank you for joining us on this deep dive into percutaneous thyroid ablation. Until next time, keep learning, keep questioning, and keep exploring.